Hi, everybody. This is Megan Barnett with BioLounge. I wanted to bring a new clinical insider today to you, focused on tooth erosion and gum recession, or other forms of periodontal disease and issues with oral health. So there's a biological dentist that I work with closely. So I've had an opportunity to work with quite a few patients that are presenting with these symptoms, and there are some patterns that arise. So I thought I'd share a recent case study with you guys today. This is a 34-year-old male. He has a 5-year history of obvious tooth decay and gum recession. And he reports that it's probably been going on longer, but he didn't really notice that it was severe until the last 5 years. And he describes the tooth erosion, that the molars and the teeth near the back of his mouth are literally breaking down to nubs. So it's very severe. Other than that, he feels good. So he's not presenting with a bunch of other symptoms. He has 3 young kids. He and his wife are little homesteaders. They focus on their diet. They eat real food. She does a lot of the cooking. So they really felt like they were on top of things. He does note that he has a sweet tooth and that he didn't have perfect oral care growing up, but he always felt good and didn't have a lot of issues with his mouth to speak of. So some things have arisen in his life over the last couple of years that may shed some light on what's going on. One of those things is that he has started snoring, and his wife says that's been going on for a while, but it's gotten worse, significantly worse recently, and mouth breathing. And then on top of that, he has slight hypertension now. So he's a normal weighted guy. He's a carpenter. He's really, really active. So we thought we would dig in, and just off the top of my head for suspicions, what I've seen consistently in these patients that have unusual tooth erosion is vitamin D deficiency is consistent. And oftentimes we see really severe vitamin C deficiency as well. So I'm in the Pacific Northwest, which means that virtually everybody needs to be taking D3. Occasionally I'll come across somebody that has a healthy D3 level without taking it, but it's pretty rare. So he has not ever taken any type of supplementation. So we decided to look at a couple of things. He hadn't had a medical panel as far back as he could remember. So we did a full medical panel. We did a very reduced food sensitivity panel. And this was just for cost because we were spending a lot of money on other things. So we just looked at sensitivity to wheat with the Vibrant panel that also identifies if there's intestinal permeability. And then we looked at a full intracellular and extracellular micronutrient panel. And so some of the more important things that came out of these labs, which you can see listed in the PDF that I include, is that his vitamin D was at 15.2. So that's a severe deficiency. Some other things that were of note were that his cholesterol was elevated, specifically his LDL was 166. So this is something that I regularly see when there's oral infections. When the body is working really hard to make extra lymphocytes or white blood cells, there is a larger demand on the production of LDL cholesterol as a precursor to making those white blood cells. So we'll often see inflammatory conditions, especially linked to infection, drive up cholesterol. Now, remember, he's snoring and he likely has sleep apnea of some degree, and we're seeing that hypertension that can lead to insulin resistance, metabolic disorders, elevated cholesterol, all sorts of things in the metabolic area. So I'm always concerned with that. And then, of course, mouth breathing can exacerbate tooth decay. So this is probably a much bigger picture, sort of chicken or the egg situation with regards to the metabolic stuff and the tooth stuff and where those are crossing over. Some other things I wanted to note is, although in the Vibrant range, triglycerides were not elevated, in my world, they're 148, and I like them under 100. This is important because his A1C is getting borderline at 5.5, but also he had a pretty significantly elevated ALT. So I'm concerned that there is fatty liver potentially. He's not a drinker, so there's not an alcohol component, but there potentially is excessive carbohydrate intake, and he does eat sweets. Some other concerns. His estradiol is very low, and oftentimes we don't care, or we don't think about this with men. We should care. We're worried over time that if estradiol is low, we have an increased risk of bone density issues, and I'm going to carry that through to teeth as well. His testosterone levels are not included in the laboratory markers because they were normal. His free testosterone was somewhere around, I think, 14 or 16, but his total was in the high 300s. Now, normal to me is whatever feels normal to the person. So if they feel like they have low libido, low drive, low motivation, hard time building muscle, we're going to look at that. He does report low libido. He says that's how he's always been. And he does not have low drive, low motivation, hard time building muscle. So I threw that out there, something for him to consider, but not something that we were going to be focusing on together. Of note, his cortisol was low, but his DHEA was normal. So the big concerns that I have from his medical panel are his white blood cells. And so you'll note that I've asked him to go take these labs back to a primary care physician. And that's because he has what we would consider leukopenia and neutropenia at this time. His white blood cell count is low and his neutrophil count is low. Of concern, his immature granulocytes are elevated. So this can indicate more severe issues. I've often seen that when we resolve infection, the immature granulocytes come down. Oftentimes we are resolving the infection and improving the micronutrient markers, which I think are playing a huge role in this. So let's look at those. In his intracellular white blood cell, red blood cell profile, he was low in quite a few nutrients that would make me concerned about his immune system and his teeth. So the B vitamins, some of the B vitamins were low. That is not uncommon, but his vitamin C was very low. His D3 was low. His K1 and K2 were both really low. So we're thinking about calcium transport potentially. And zinc and copper were both very low. So copper is something that I'm always thinking about with regards to white blood cells. Magnesium was low. Carnitine was low. As a note, this is something that I never, ever supplement with when somebody has cardiovascular risk. And this is because it can increase TMA in the gut and then TMAO through the liver and increase risk of cardiovascular disease. I will increase foods that have carnitine in them, but I don't give a supplement for this. And there's some pretty solid research around why that can be risky. CoQ10 was quite low, cysteine, selenium, and omega-3. So we have a lot of work to do here from a supplement perspective and a nutrition perspective. Like I said, he's eating a whole food diet. What really needs to be worked on here is that he's consuming more fruits and vegetables and he's getting the sugars out of his diet. The last thing that we looked at is his intestinal permeability panel. And he does have a high sensitivity to wheat. He did have some antibodies against zonulin and actin. So we're seeing some intestinal permeability for sure. And then, the bright, shiny, flashing red light here for me is anti-lipopolysaccharide toxicity. But we do see this in intestinal permeability when it's sustained for long enough. But I also see this more commonly with people that have some sort of bacterial load within a root canal site, an old cavitation from wisdom teeth. They have periodontal disease, they have tooth erosion. That's a straight shot for lipopolysaccharide to move into the capillaries through the endodontic tissue. So that is not a surprise to me. He very well is probably passing lipopolysaccharide through intestinal permeability channels as well. But that lipopolysaccharide presence is common with people that are having oral health issues or have unknown infections within the root canal or other endodontic tissue. So we have all of these concerns. And so one of the considerations that I had to make was that he doesn't take pills. So we needed to find supplements that were liquid, powder, and chewable, which did. And you'll see that that's why we have what we have in the interventions. He's agreed to remove all wheat and gluten out of his diet for 90 days. We have a pretty sturdy supplement intervention. I've asked him to avoid sugar and refined carbohydrates. I gave him a low carb menu for that. And then the other thing we talked about, due to the likelihood of fatty liver, is doing an intermittent fast 1 to 2 days a week. So dropping calories down to 600 calories, doing plant-based, very low protein, putting his body into a state where it can do some pulling of those triglycerides out of the liver, but also some autophagy, some, getting rid of these more dangerous cells and hopefully doing some regeneration. And then I've also asked him to follow up with his biological dentist and start getting this work done. The biological dentist won't do the work with him until we have his vitamin D levels above 50. And that's because they're so concerned about healing. So they're going to get this on the schedule and start working on this. We can get his vitamin D levels up within a couple of months to that level. I've asked him to have a carotid intima media test to look at any potential plaque buildup, because I am concerned about what's been going on with his cardiovascular health. And then to follow up with his primary care for a sleep test, to look at the labs to track these white blood cells. So all of that work will be done under primary care in combination with what he's doing nutritionally. So in this specific clinical insider, this is a recent case, and I don't have follow-ups for you. These type of resolutions take up to a year, sometimes a little bit longer. We can see a lot of improvement in symptoms pretty quickly, but his symptoms being degradation of actual tissue, this takes much longer. So my plan is to retest his white blood cells in 30 days, just to put my mind at ease, to be honest with you, and to make sure we're going in the right direction. We'll look at his vitamin D at that point as well, and just make sure that we're being as aggressive as we need to, and then continue to work through this plan for probably 6 to 12 months. So I hope that was helpful for you. Please stay tuned on our clinical insiders. We try to put these out every month or so, and we do have a new clinical immersion program, our 12-week clinical immersion program starting in September. September 16th will be the launch. So if you're looking to dig more into clinical practice and gain some mentorship around these conditions that we're seeing so commonly now, reach out to me. I'd love to talk to you more about the program. All for now. Enjoy your day.